do you think?
Well, there's causal reaction.
Yeah.
But it's hard to say if there's any loosening.
Right. I think, yes, that's right.
So, so this lady's symptoms of pain.
It really has little symptoms at all.
Yeah, but this is happening.
Yes. A week after going home, she's okay. No, and she's been a very active dancer. She actually performed.
It's a routine review. But so the issues are that she's demonstrating where her she may go on to further wear and then
So when if you haven't seen her for 5 years and she comes in for reasons, say you wrote to her and asked her to come back to her check, you find that X-ray and no symptoms.
I'll explain that there's signs that she's getting wear.
Yeah.
But that's expected with a mental holiday.
Yeah, 15 years. Yeah.
And it's not functional. Out of all the normal activities.
Yeah.
Review her more regularly to see types of bony aseptic loosening.
Right.
Prevalent with
So
actually 6 months.
yeah, so that's, I mean, I saw her regularly and
Loosening in one and two.
not, hang on, what is it?
Sorry.
Yeah.
Otherwise,
It still has no symptoms.
remainder of the prosthesis is well fixed.
Yeah.
Developing signs of now goes into whether there's probable loosening or definite without symptoms or any startup pain features. There's no likely the prosthesis is loose.
I don't think it's loose at all, but she does have secondary damage occurring to the surrounding bone. Further revision a little bit more difficult, complicated.
Yeah.
And often you find when you highlight those things to people who show their concern, they in fact do have some symptoms. So she comes back, oh,
The options now to revision procedure, whether or not the options would be to revise the policy. If this prosthesis which the holes can be finally packed both,
yeah,
and there are a change in liner,
yeah,
or a complete change of the
right.
help address
sorry, did you say, hey, you're just going to put a new poly in? Grafted? Yeah.
With myself, I don't have components ready for the complete implant. But at the time of the operation, it has holes in it, and the option would be to finally pack the photograph and change the hole.
There is one hole, just the central hole. Yeah, that's it. What are the indications for revising an otherwise well-fixed bone, well-fixed cup that has osteolysis behind it?
So definite loosening, so loosening.
No, well fixed.
Well fixed. Oh, that's progressive loosening around the body. If it's for it, it's a.
Yeah, so I think you've sort of hinted at them. If you've got areas of osteolysis that you can't graft, or that you're not happy to leave, and you can't get to them through the cup or around the cup, sometimes you can make a hole up here. Or if you don't have a polyethylene that will go into it, and you're unhappy to cement a liner into it, or if it's a capture mechanism which is unacceptable for quality, or if the cup's so badly malpositioned, you would be unhappy leaving it because of the sort of risk of dislocation. I did all this myself, and I'm really unhappy and have been since day one. I'm itching to change it. Because I think that's sort of really the reason it wore out. So. But it did wear out. I think it's debatable whether you need to change the whole cup, and I think I am going to change it. I can tell you at the time of surgery, if ahead of time you said, well, if it's well fixed, I won't change it, you won't be changing it because it adds another hour to the operation. You'll just change the wire because it's so much easier to do than taking that cup out. I've decided I'm going to change the cup. But it's arguable. All right, it's 6 o'clock. Yep, all right. Here's another one. This chap is 92 years old. He doesn't speak English, he speaks Mandarin very well. He had this China hip replacement done some 20 years previously, I think it was. He's got a lot of pain. A bit hard to see, isn't it? Well, if I tell you it looks fine. Defects in the cement, no osteolysis. Doesn't look like it's subsided. Probably articulating with the check. Does it really hurts? Really hurts off. Do you have a classification for bone loss in revision? Segmental bone loss. What's this? Yeah, it's combined. Yeah. And have a turn.
Worry. I mean, the video will look too bad, but yes, it's scan. I'd be worried that there's something there.
Right. Well, there is breakage of Kohler's line, I agree. And how far is that cut migrated upwards? Yeah. Yep. So it's gone upwards and it's gone inwards a bit. So, and it's lost bone. So you've lost, what you're really trying to assess from the x-rays, how much bone is going to be available afterwards to get fixation with an uncemented. How much is left in the columns, anteriorly and posteriorly? How much is left in the floor? How much is left in the... higher up it goes, the more you lose from the columns, anteriorly and posteriorly. Get an idea of how much bone is missing from the posterior column. Oblique views will see it. If there's osteolysis in the ischium, Kohler's line is broken. You've got to be, that sort of indicates that there's a medial floor defect. And if you can't see the teardrop, then you've got a major medial floor defect. Well, I can pick all those things up from the plain AP X-ray. So there's going to be a big defect here in the column loss anteriorly, possibly posteriorly. Be worried that there's certainly a medial defect, so there may be a association, as you say. I find Paprosky's classification a little bit more helpful from that, and Alan Gross has got a good classification as well. But they looked at all those things. They looked at what change has happened with the cup and what damage has that done to the. What about on the femur? Are we going to revise the femur? What are the options? So you could just leave that Charlie stem in. Yeah. What's the problem with doing that? Two heads. You'd have to have a 22 heads, wouldn't you? Yeah. Okay. So can you get it? Is there an alternative to that? Cement. Yeah, it's got a good interface. You can't see it if the plug goes down to about there. So yeah, that would be a big procedure for this guy who is 90. Another option is to use the cement mantle that's there and cement another stem, a contemporary stem that you can put a bigger head onto. And there is an Exeter stem that's designed to go in. But to me, that would be a simpler